Well, thanks. I'm Linda. This is Carrie. And why don't the members of our team just stand up? I know there aren't very many here. But we've got Rachel Nygaard and Emily Halou and our star community advisor, Mohammed Badasso, who you saw in the video. And our other community advisor, Kong Bang, is not here, but they were both really great members of our team. And I just want to say, Mohammed, that sometimes I felt like I wanted to apologize for us. and I do just want to remind everybody here that a corporation is not a person. If it were, we could respond much more quickly and change much more quickly, but we are a big, slow-moving thing, and we're working on it. So thanks for your encouragement. Yeah. There you go. All right. So as a group, our goal is to increase, our overall goal is to increase screening colonoscopy rates for Somali and Hmong patients. But to reduce that down to something a little more workable, our aim is to decrease barriers to scheduling and completing colonoscopy for these patients. And really, we probably should have backed off on that and made it to identify barriers to screening and completing. So this is just going to be, really this is more of an overview of our experience as an EBAN group, not all the specifics of every little piece of data, but kind of how this went as an EBAN experience. And in the evaluation, I'm going to start out with the challenges. Colonoscopy, like some of these other topics, is a really challenging topic for not just new members of our community from cultures where this was never heard of, but for people who have been in this country for many, many years, whose generations go back, who have the means to do this whenever it's recommended. Nobody wants to do it. So that is very, very much a challenge. And it's very complicated to get it done as well. It's to get a completed colonoscopy, not just a fit test, which you'll hear more about later, but to get it scheduled, to get the day off of work, maybe the day before off of work, to do the prep, which is really unpleasant, blah, 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 get a ride home. It's really complicated, so there are lots of aspects that need to be worked on. I mentioned this a little bit before. Our aim was a little too broad. We're really just beginning to address some of these barriers to these populations, but at least we're starting. We're going in the right direction. Another challenge to us as a group was changes in the membership of our group. And not just the membership, but in the leadership. Carrie is now our one surviving leader in the group. But that's really challenging to keep momentum going when you've got changes in the group membership. And I know that's just a reality. So we need to, kind of figure out how do you maintain that momentum when you've got that going on. And I know this is a challenge to everybody, but it's time. Having enough time, having time dedicated to do a good job of this. And even though it sort of felt, I'm sure to everyone again, like there's another project, EBAN, but it really is the opportunity to take some time and dedicate some time to really trying to make some changes here. So the successes that we had, I think number one is beginning to break through a number of silos. Each of us has our own silo, whether you're behind some walls or in your little office or from one side of the building to another, from primary to specialty. That's a scary step to take. And the biggest step that we have to take, and we're starting to take, is out into the community. And it's a really important thing for us to keep doing. So I think this was just a great way to realize that we can do this. We will face questions that we can't answer, things we don't know, but we're creating trust as we go. So that's a great thing. Another success was leveraging some of our organizational resources, first of all, to establish some new preventive service reporting down to the language and country of origin level, which was done for us by Care Innovation Management for colonoscopy and mammography screening. So we knew that there were obvious differences by race, but to look at African American versus white, we know within African American there are a lot of different groups that get lumped into that group. So to be able to look at these differences by language was really helpful, and just kind of supported what we thought was probably going on. Through our community, and also the outreach database, which was created for us with Sarah Horst Evans and her resources. It really helped us to be able to not just do outreach calling to patients overdue for colonoscopy from those scheduled orders. Those of you working in clinics, you know what that is. You know, people who have an order scheduled to do it. But these are people who don't even know they're overdue. They haven't maybe been into the clinic in a long time. And but in our data, we know that they're overdue, and we can start doing outreach calls to those people. We haven't yet got the resources to have interpreters doing those calls for us, but you'll hear about that in the mammography group a little bit. Again, through our community advisors, I feel like we were successful in gaining awareness. They were helpful in one of the projects, one of our PDSAs was a walkthrough with our community advisors through the colonoscopy process at the St. Paul Specialty Center. And they didn't have to experience the colonoscopy or watch one, but they went from the check-in desk into the little prep room and walked through the area. And we just kind of talked about what would be happening at each point, and they were able to give us feedback as to how we could do it better, where there may be some barriers there as well. Also, for some of us, you know, we all came into this with different levels of quality improvement experience, but having to do these things and hearing Dan Nelson in the back of our heads when we're back at our team meetings talking about doing PDSAs and sticking with it, you just have to do that stuff, and you know, it's a good chance to really learn. And even though I think it may not have seemed like it so much in the last few months, I feel like we are gaining some momentum now. And mentioning Sarah again, who's going to be coming onto this team formally as we move on, they did a Sharing at Work grant, and we did get awarded to this group a $10,000 grant to do some specific outreach to these two communities, Hmong and Somali, or East African communities, and maybe even do a little more work with getting some, I want to call them community health workers. Maybe that's not the term I should be using here, but some, what is the word we're using, interns?
I was going to call them ambassadors.
Ambassadors, yes.
Interns, free ambassadors in the community.
Yeah, so really getting a deeper connection to the community through community members themselves. So.
Okay. So our sustainability, I hope you can hear me. What, are we likely to sustain the work that we're doing? And like Linda said, yes. We are really now kind of getting into that motion, and I think with having, thanks, thought it was loud now, having Sarah on board and getting some more data and results now is getting us a little bit more excited. The thing with colonoscopies is the data can come 3 to 6 months later. Because you schedule an appointment, it may not be for 3 to 6 months before the procedure is completed, and we wouldn't know if they actually completed it until that time. We are having some relationships in our organization. A real key that came on board was primary care now. There was a pilot out, there's 5 primary care clinics, including the appointment center, who have been allowed to schedule screening colonoscopies for our patients upon exit of their primary care visit. That has never happened since. It's GI has always owned the scheduling piece, so it did make it very difficult for patients upon exiting their annual exam to schedule a colonoscopy, because the MOA would have to call the GI clinic would have to find the schedule, then we got to report it back, and does this time work? And so that, I think, is going really well. We're still getting some data on that, and if we're improving our scores. Challenges are challenging to acquire resources to fuel our group's ideas. Time, that's always one of those resources that's very difficult. Everyone's very busy and finding the time to do it. As well as additional staff with interpreters. That was a big one that we came up with just a few months ago. Parkway Clinic, who has the West Side GI, is very fortunate, who has a very fluent Hmong MOA. We utilized her out of our data, the database that Sarah created, to gather just all the Hmong speaking patients, and we utilized her to call those patients, to schedule, to answer their questions. We don't have the data that I know of yet because that was just happened a couple months ago, so we got to wait until they actually come in, make sure they've completed their procedure. And was that valuable? Using interpreters at the point of the call, valuable to those patients that we were calling. Like Linda said earlier, we've had some change in our team members, but I think with our group that we have very dedicated people. And so we will be continuing this going forward. This is not the end for us. We are continuing this as we go. How do we spread this? Change takes commitment and time, so challenging in an environment of consistently emerging initiatives. This all goes back to the time, busy, all these other things to do, but we will be continuing going forward. And coordinating enterprise-wide outreach could be used to promote all preventative screenings. So like utilizing the local community media. There is a Hmong radio station that we're going to try and hook into with our Sharing Network grant to do some radio spots, as well as there's a Somali television station, I believe, that we're also going to try to utilize some television spots into with our Sharing Network grant. As well as getting out into the community and doing some gathering in places. We found out that a good place to go would be like to the markets and doing some health fair there, just some information for the gathering of in the summer down in Minneapolis or St. Paul's farmers markets. And considering embedding community leader connections within the enterprise, just getting some more maybe advisory panels into, like Linda said earlier, what things do we not know that we don't know, that we just do every day, One of the examples was that we found out when the patients come into the exam room, the gowns were laying out. It appeared to be that then they're dirty. We would have never thought that's just how we do it. But to some patients, it appears that I don't want to put this on. It's dirty. Why is it sitting out? So it's just those little simple changes, but we need some more of that feedback in order to know what those little changes that we would never think of. And I think that's it.